Hare Krishna, good morning. I'm Dr. Manish, and in the next 10 minutes, I'm going to speak on a topic which is related to the novel antibiotics which you are going to use in your ICU and how your practice of your antimicrobials is influencing your day-to-day practice. This is something which we are going to explore in the next 15 minutes or so. So before I start onto this journey, let me acknowledge the presence of Lord Krishna, under whose guidance I have been able to achieve, I have been able to fathom the majority part of my learnings, and my every work is dedicated to the lotus feet of this Supreme Consciousness. Thank you. Now, my topic, which I'm going to speak today, is with respect to the neuroantibiotics for the superbugs, which you are going to witness or which you are actually witnessing on day-to-day basis in your clinical practice, in your ICUs. And in the next 12 to 15 minutes, I'm going to decode that how you are going to use them rationally and effectively so to achieve the best possible outcome for your patients. Now, before I go forward into the journey, the first and foremost, I would like to know from you, how many of you are actually using novel antibiotics in their ICU? Can you raise your hands up? Thank you. And how many of you have been actually endorsing the use of this novel antibiotics? Hands up, please. Thank you. The reason why I asked you this question is because uh, I have a disclaimer which I have attached to this presentation. My training, my practices has been endorsed from the transplant critical care medicine, where I have been working with the transplant physicians and the surgeons, because where we were more infatuated by the sepsis surveillance and the sepsis control, the source control techniques, rather than getting fascinated by the neuroantimicrobials. That is not something which we have been doing it otherwise in the past. Now, if you talk about antimicrobial resistance and the new drugs, it's something which look very funny and very mesmerizing at the same time. When Dr. Pradeep called me up on 1st of October, 2024, I was both amused as well as I was perplexed. The reason why, because this is one disease, the antimicrobial resistance, where we first create the disease, then we treat the disease, and then we publish the disease. It's a man-made disaster. It's something like a hamster or a rooster who is just there treading the hedonic treadmill. Antimicrobial resistance, my dear friends, is a top 10 global public health threats. Almost 7 lakh deaths we have witnessed on an annual basis, and they are expected to compound by 10 million deaths by 2050. And that's why you need to have a super drugs for the superbugs. Between 1990 to 2015, almost for 25 years, we were actually into the independent loop. There was a complete discovery void when almost virtually no antimicrobial has been added into the compendium of critical care practice. And with the rising burden of the superbugs, we were heading into the era where the post-antibiotic era, which we call it as, was not far. Thanks to the last decade or so, where almost 12 antimicrobials has been added, at least into the compendium of the Indian pharmacy. Now, in order to understand this subject better, let me put you and let me get you across this case. A middle-aged female, 50 years, unknown case of CLD, coming to you with a history of fever, TLC rise, high FiO2, and the clinical pulmonary infection score of 8, suggestive of that the patient is having a VAP. When you have this kind of a situation, obviously you treat them with one or either combination, which is mentioned as, and you can see on the X-ray that the patient is having right basilar pneumonia. Now, the question is that what should be the ideal treatment? Now, before you answer this question, and before we actually reach to certain conclusion, what we need to understand that what are our problems? What are problems in this country? Carbapenem resistance is around 40%, which means 4 out of the 10 Even if you start them on carbapenems, they're not going to respond. Oxa 48 NDM, which means amber class C and D, they are the predominant carbapenemesis in this country. And you must anticipate these issues before you prescribe an empirical antibiotic regimen for the sickest patient in your ICU. Why we are worried about carbapenem resistance or the carbapenem resistance into Rubictris or intravitreal? Because if you go into this meta-analysis, it is clearly mentioned that patients who have been having a CRV, they have increased mortality in comparison to the patients who have carbapenem sensitivity intravitreal. And this mortality has been seen at 6 days, 7 days, even at 14 days. It has found to be on the high side. So what options do we have when it comes to the treatment of this MDR-HDR pathogens? We have basically the four major categories. One is BLBLI. The second is cefiderocol. The third is plasmomycin, which is a novel semi-synthetic aminoglycosides. And the last one is irabicycline, which is basically a tetracycline drug, although found to be more potent for gram-positive and gram-negative in comparison to your tigecycline and your doxycycline. The core of your antimicrobial regimen for the patients in this country, I think somewhere they are based on ceftazidime and Bactam. Now, let me acknowledge this fact that I have no conflict of interest with the Pfizer or any of the company, but we need to understand that why ceftazidime and Bactam has been drafted or has been led as the core of your therapy when it comes to the MDR-HDR pathogen. Ceftazidime is the third generation cephalosporin, obviously like your cefoperazone and ceftriaxone. However, the uniqueness is mainly because of avibactam, which is a non-beta-lactam beta-lactamase inhibitor. It has been approved for almost every possible hospital-acquired infection. But what is unique about this drug is that it works wonders when it comes to the ASPL, KPCs, and even Oxa 48. However, in case if you are suspecting the patient to have Acinetobacter, or if you are talking about NDM, which is your New Delhi metallobutyllactomesis, then there are high chances that you're going to fail in this combination, with this combination. So make sure when you're treating the patients, they have to be on ceftazidime and avibactam. It works wonders when you're talking about oxaliplatin. Now, you talk about the guidelines that has led to the reason why ceftazidime is a part of protocol, whether you talk about the Spanish Society of Chemotherapy, the NICE guideline, the Surgical Infection Society, or the British Society for Antimicrobial Chemotherapy, almost all of them, they have been really endorsing the ceftazidime avibactam as a part of their core therapy. However, you just have to make sure that you are not using it for metallobutyllactomesis, right? And ceftazidime avibactam has been used in various combinations with astronam or maybe even with polymyxins. So as per the IDS endorsements, which is given in 2022 August, patients who have been having a metallobutyllactomesis, which means NDM, WEM, or IMP as on the basis of gene homology, they are the one who should be given ceftazidime avibactam in combination with astronam. Astronam is a monobactam which has been found to be effective against the metallobutyllactomesis. Now, ceftazidime works for your ceftazidime works for your Oxa 48. Astronam works for your, as I shared with you, it's for your NDM. Now, in case if you want to use any alternatives, you can certainly try the tigecycline, irabicycline, which are found to be good alternatives. Cefiderocol, I will get onto the cefiderocol in the next couple of minutes. Elora is a unique drug found to be in vitro activity against the gram-negative metalloproteinexemesis, given by Manu Chaudhary from Venus Remedies, launched in 2013 after the approval from DCGI. has been found to be effective against varied gram-negative pathogens. However, there are no CLSI guidelines to confirm sensitivity pattern. Also, the in vitro sensitivity may not get reflected truly in vivo efficacy when it comes to the Indian X-ray pathogens. As I was talking about Astronam in combination with avibactam. Avibactam, as we know, it works against the OXA, which is a part of your serine uh, moiety for the beta-lactamases. And Astronam is one which is found to be effective against the metallo-beta-lactamases. And this has been endorsed from the Rejuvenate study, which was done for intra-abdominal infections, and also a part of your dual carbapinamase study, which is got published, I think, somewhere around 2020 in American Society for Microbiology. Often when the patient is sick, who's there in an ICU and is having a septic shock and is likely to die, we tend to overthrow the antibiotics by giving them ceftazidime in combination with estronam along with polymyxin as well. Now, this combination is based 90% on anticipation and fear. We don't have a significant evidence when it comes to this strategy. And although it's a polymyxin sparing, so it helps you in reducing the dose and maybe even to spare the polymyxin. Meropenem viborbactam. It's there in this country with the name of Vivomir, works for your gram-negative MDR enterobacteriaceae family. More specifically, we're talking about the ESBL. It doesn't work when it comes to the Indian. Almost can be used for almost every possible. So it is much more inferior. It is much inferior when it comes to if you compare it with your ceftazidime and avibactam. Ceftolozane tazobactam. Now, this is another BL-BLI combination, which you can use, available with the name of Zerbexa. However, it has no activity against New Delhi metallo-beta-lactamases or IVL-KPC. So it's a drug which is used mainly for ESBL infections, and it is used in combination with anabolic cover-up like metronidazole. Cefiderocol. Now, this looks a brahmastra when it comes to the choice of antibacterial therapy. In 2022, when there was a critical care update which got happened, this has been drafted in them and it has been seeked as one of the pan solution for MDR X-ray pathogen in this country. It has a unique mechanism that it binds to the free iron and basically it works through the iron transport system, mainly used for gram-negative pathogens. FDA has approved, and it is used in a dose of 2 grams every 8 hourly as a 3-hour infusion. Make sure you are taking care of potassium and your liver enzymes. The transaminitis is quite common with them. A possible game changer, which has been given by this country from Vopar company, like the drug which is cefepime and zidibactam, especially it has been found to be effective against OXA48 and even New Delhi metallo-beta-lactamases. Its use has been prescribed, or I would say it has been endorsed for the compassionate use when nothing is working. It is found to be specially endorsed for the drug-resistant pseudomonas. Now, the cefepime and metazobactam, again, a novel BL-BLI combination. It inhibits ESBL-KPC, but has a limited activity against NDM and OXA48. And why we are close to it? Because why we are close to this medication, why we are close to this antimicrobial is because of the fact that this drug, in combination with Orchid Pharma, has been launched as a new antibiotic from this country. So this country has given you 3 major combinations, including cefepime and metazobactam, your ceftriaxone with EDTA and sulbactam combination, and your levofloxacin. Plasmicin availability in limited centers is simple has taken approval from Central Drugs Standard Control Organization to market it. Works for your ESBL, CRD, It also shows against your Acinetobacter, has a beautiful action against MRSA. The main biggest disadvantage is the cost, which is approximately $600 per week of therapy. Irabacycline, one of the broadest gram-negative, gram-pathogen, gram-positive cover-up, which can be given in the form of coming by the name of Xerava, has a more potent than tetracycline for gram-positive peptide GMP, and also bacteroids and immunoglobulin. The cost is a big limiting factor. It has been used, its use has been prescribed for intra-abdominal infection, even for UTI. However, it should not be used for the bacteremia. Now, there's a paper which has got published as iconic study in 2019. There's also iconic 2, which has got published in 2024. The paper is unique in the form that it has been having a contribution from 2 to 3 um, from 3 renowned intensivists, including Dr. Ashit Hegde, Dr. Yatin Mehta, and Dr. Subhash Todi, and where they have been given with respect to that how you can choose the novel antimicrobials in your ICU. So with this, I would like to bring it to the last slide, which is what is your home message? Antimicrobial resistance is a medical emergency. It's a man-made pandemic. Knowing your local epidemiology is mandatory in today's contemporary critical care practice, and it is not optional. Carbapenem resistance is around 50% in this country, so you have to be very careful for your empirical choice, especially in the setups which has more than 20 to 25% prevalence for the KPCs or NDM or osafortate in their ICU. NDM, osafortate are our biggest problems. Point of care of testing is a near of R, including the use of CARBA, including the use of expert CARBA R and BioFire film array, which can gives you the results in a very fast forward possible manner, and also has a potential to hasten the outcome of your cases. Ceftazidime, ivermectin, either in combination with istunam or polymyxins, has been plausibly a choice of combination therapy in patients with high-risk CRE. Novel antimicrobials is not an antidote against the sepsis source control. So if your patient is having a sepsis, please, starting the antibiotics should not delay the source control retrieval in these cases. Otherwise, post-antibiotic era is not far. Thank you, Team Jakes, for having me here and giving me this opportunity to present in presence of the esteemed individuals. Thank you.